A warm good evening to all of you. This is the first meeting of the year 2026. So on behalf of Calicut Surgical Club, we wish you a warm happy new year, and we hope that this series of meetings continue without any interruption throughout this year. So coming to the agenda, first we will have a silent prayer, then we will have the minutes of the past year's last meeting, and then we will go on to the academic session. Okay, so kindly rise for a silent prayer. Thank you. So I recognize the presence of many senior faculties, our teachers, and budding new surgeons over here. So I invite Dr. Dinulal, Secretary, to present the minutes of the previous meeting.
Good evening all. Last meeting was on 10/12/2025 at Hotel Hyzen. Before meeting, we conducted an executive committee meeting. That was the last meeting of Dr. Ramesh and Dr. Abba, and new office bearers were nominated. Dr. Arunas as president, Dr. Dinulal as secretary, and Umar Fadil as treasurer. Last meeting was attended by around 50. Meeting was called to order by the president, Dr. Ramesh. After that, silent prayer. PG topic presented by the George Aditya Paul. He's junior resident at Calicut Medical College. The topic was a case of multiple gist. And the main talk by Dr. Srikanth, HOD of Surgical Oncology Department, Calicut Medical College. The topic was hype or hope. Can the minute be passed? So without any delay, we can start the next academic session, that is PG topic by our Sonu Kumar, Dr. Sonu Kumar from KMCT Medical College. I invite Sonu Kumar.
Respected senior faculty, my co-PGs, and other doctors, a very good evening to one and all. Today I have a patient named Hajara, a 55-year-old female coming from Vadagara. Her occupation is she's a housewife. Her chief complaints was swelling in front of the neck for 10 years and swelling over the scalp for 8 months. She was apparently normal 10 years back when she noticed swelling in front of her neck. It was insidious in onset, initially small in size and gradually progressed to reach the present size. There is no history of any pressure symptoms. There is no history of hyper or hypothyroidism. She also complains of a painless swelling over the left side of her scalp for the past 8 months, which was insidious in onset, initially small in size, and rapidly progressed to reach the present size over the past 2 months. There is no history of any vomiting, headache, seizures, or visual disturbances. There is no other any other swellings in the body. There is no history of fever, cough, and hemoptysis. No history of any significant weight loss or weight gain. No history of back pain, long bone pains, jaundice, or abdominal distension. And now, past history, there is no any significant past history. There is no any history of radiation exposure or prior surgery or any other malignancy. Personal history, she's on non-veg diet, normal sleep and appetite, normal bowel and bladder habits, and there is no history of any addictions. Menstrual history is also somewhat normal. She attained menarche at 13 years, no menstrual abnormalities, and first childbirth was in 22 years. In the family history, her mother had a swelling, thyroid swelling in the neck, for which she didn't undergo any treatment. There were not documented details available, and there is no other history of hypertension, DM, or bronchial asthma or CAD in the family. There is no other malignancy history in the family. Examination after taking consent, ensuring adequate privacy. She was examined in a well-lighted room in sitting position. General physical examination. She is conscious oriented to time, place and person. Thin built and poorly nourished. She's having there is no history, no icterus, no clubbing, no cyanosis or generalized lymphadenopathy. Her BMI is 21.5 kilogram per meter square, and Karnofsky performance status is 80. And in head and toe examination, her hair is normal, no alopecia. There is no facial puffiness or loss of lateral eyebrows. There is no tremors. Eye signs are absent. Her nail is normal. Skin of the hand is normal. We have a swelling in the left scalp that is 3 into 2 centimeter. Patient vitals were stable, 86 beats per minute, regular in rhythm, normal, volume and character. Sleeping pulse rate was 78, and all peripheral pulses were palpable. The BP and respiratory rate was within normal limits. And about inspection, the skin of the swelling was normal. There is no distended veins or scars or sinuses or redness or visible pulsations. The swelling was of size 18 to 5 centimeter on the anterior aspect of the neck in the midline. It was extending from the upper border of the thyroid cartilage to the sternal notch craniocaudally, and 6 centimeter to the anterior border of the right sternocleidomastoid, and 3 centimeter to the left from the midline. And lower border were not visible even during deglutition. The surface appears nodular and well-defined margin. Swelling moves upward with deglutition but does not move with protrusion of tongue. The Pemberton's test was positive, and trachea is mildly deviated to the left. On palpation, you have no localized of temperature, no tenderness. Confirm the findings of inspection. We have a diffusely enlarged thyroid gland with multiple nodules, largest on right side of size 5 into 4 centimeter, and it is firm in consistency. On the left side, you have it is firm in consistency 3 into 2 centimeter. Another harder nodule, which measures 1.5 to 1 centimeter, is palpated in the right side. The plane of the swelling is deep to deep fascia and deep to sternocleidomastoid. The lower border was not palpable. Coach's touch is negative. Got a cervical lymph node palpable at level 4. On the right side, it is 2 into 2 centimeter, firm, non-matted, and non-tender. There is bilateral carotid pulses were palpable. On percussion, there was dull note over the upper part of mammalian sternum. On auscultation, there were no bruit. And about the swelling in the scalp, it is of size 3 into 3 centimeter in the left occipital region. Skin of the swelling was normal. It is oval in shape, well-defined margins. It was non-tender, non-pulsatile. It was fixed to bone with variable consistency. And there was no bony defects palpable, no bruit, thrill, no expansile impulse on cuffing was there. and systemic examination was within normal limits. There was nothing significant, and CNS higher mental dimensions were normal. No focal neurological deficits, no resting tremors, and musculoskeletal system too. There was no skull or spine lesions. I'm just summarizing this. We have a 55-year-old female without any non-comorbidities, presented with painless swelling in front of neck, 10 years, with a scalp swelling of 8 months, not associated with any significant weight loss, no compression symptoms, no history of any hypo or hyperthyroidism. We have another like thyroid 7 into 4 centimeter swelling on examination in the neck, which is more on the right side, firm in consistency. Margins are defined, not fixed to underlying structure of skin. There is no toxic signs, but there is evidence of retrosternal extension. Scalp swelling is 3 into 2 centimeter, oval shaped, firm swelling, margins defined, fixed to the underlying bone. The provisional DD was multinodular goiter with retrosternal extension in euthyroid state, probably carcinoma thyroid, papillary carcinoma with lymph node mets and with scalp mets, staged as T4 N1B M1. What he underwent was total thyroidectomy plus type 3 modified radical neck dissection with elective tracheostomy. And her blood routine was hemoglobin was 9.4, the TFT was within normal limits. Next neck tracheus mildly deviated to the left side. The USG neck showed multiple hyperechoic nodules of varying size in both lobes, which is of Tirard's 4 with retrosternal extension to the left. We have an hyperechoic lesion with vascularity in the right level 4, which is likely lymph node, which was suspicious. And FNAC showed from the thyroid mainly cystic macrophages and colloid with occasional groups of atypical follicular epithelial cells. And from lymph node and scalp swelling, which was suggestive of metastasis from well-differentiated thyroid carcinoma. A CECT thorax was done. That we have findings which is consistent with metastatic thyroid carcinoma with thyroidal mass. Also, we have an expansile lytic lesion in the right occipital bone with intracranial extension and heterogeneous enhancement consistent with osseous metastasis. We also have multiple small pulmonary nodules in bilateral lobes, likely metastatic deposits. HPR came as total thyroidectomy. And total thyroidectomy specimen showed invasive encapsulated follicular variant of papillary carcinoma thyroid, and with central compartment dissection was done, which invert 2 by 2 nodes, lymph nodes were was with metastasis. Extranodal extension was present, and level 2, the 3 and 4 nodes of 26 nodes, 1 was metastasis. Just concluding this, follicular variant of papillary carcinoma thyroid has both a character of vascular and lymphatic mets. It is not pulsatile, sir.
But it is highly vascular one.
Sir.
So whether it is possible if pulsatile also. This could be possibly a follicular variant of papillary carcinoma.
Sir.
You said, isn't it?
Yes, sir.
Why was the elective tracheostomy done? Was the coccus test positive?
Sir, in drop we had from the right lobe recurrent laryngeal nerve was passing very close, like it was just through the lobe, and there was a tracheomalacia.
Well, that's the reason why you did a
So we had an elective
tracheostomy.
sir.
Is that positive? Coccus test is positive?
Sir,
Coccus test? Was it positive?
yes, yes.
Was there a stride around palpation?
No,
General
sir.
palpation?
No.
It's a pretty unusual case because often when it makes a follicular variant, it could either be a follicular carcinoma, which is a transformation of a long-standing multinodular goiter with a scalp pulsatile secondary, or it has turned out to be a follicular variant of papillary carcinoma. What did he do with the scalp swelling? Well, FNAC was done. What is the finding?
Sir, it was suggestive of a metastatic lesion from this well-differentiated thyroid.
Often the meds from follicular carcinoma are pulsatile. This was not pulsatile according to you, isn't it?
Yes, sir.
How do you deal with this swelling after surgery?
So we have to keep the patient in follow-up. We'll have to wait for the 5 times raise in the TSH levels, and maybe next we'll have to go for a radioiodine scan, and I will have to check for the uptake in that lesion, and we'll have to go
In
for
this
radiography.
context, what are the other pulsatile swellings in the scalp? Other clinical situations where you might get pulsatile swellings?
So metastasis from carcinoma colon, metastasis from carcinoma breast.
Commoner ones. Pulsatile. Renal cell carcinoma. HCC. Bronchogenic carcinoma. Prostatic cancer, which is not applicable in this case. Okay? Thank you.
The FNAC done was ultrasound guided on the thyroid,
Yes, sir.
ultrasound guided,
Guided, yes.
but it didn't show any papillary carcinoma.
Sir,
The FNAC,
it was sir, it was USG guided, but we
what
got
was the FNAC from the thyroid?
it was colloid with occasional groups of atypical follicular epithelial cells.
But it was ultrasound guided.
Yes, sir.
Sure.
Sir, any questions?
Yes, sir. Require.
You said it is deep to the investing layer of fascia and deep to the sternum ludomastoid. What is the significance of that? Looking for both, or what is the relation between investing layer and the sternomastoid? Is it any relation between these two? Or is it necessary to look for deep to fascia and deep to muscle, or
These are deep to the fascia to
so will you look for deep to fascia?
so clinically will extend the neck and
So any relation between the fascia and the sternomastoid? No relation. See, you are describing the swelling as multiple nodules. You describe each nodules separately. What is the significance of that? It's just a multinodular goiter, you can say that.
yes, sir. So one nodule was a bit calcified on the right side.
Calcified. How can you say it is calcified or clinically?
So it was hard.
All
No.
hard swellings are calcified. So in this patient, you have examined the abdomen actually.
Yes, sir.
For what?
Uh,
Here there is a swelling. You said it is a pulsatile. No, it was not
it's
pulsatile.
not pulsatile, sir.
Suppose it is a pulsatile swelling and having a thyroid swelling there. And what is the significance of examining the abdomen? Already we discussed it.
No more questions from the floor? So, okay. Sonu, thank you, Sonu.
Thank you.
So, I invite the main speaker, or guest speaker, Dr. Mohammed Niaz, for the main talk. He is consultant in infectious disease at KIMS Health, Trivandrum, Faculty of Infectious Diseases at Doc Tutorials, completed MD General Medicine at Calicut Medical College, DM in Infectious Disease from AIMS, New Delhi. He is the first candidate from Kerala for infectious disease. He has more than 50 publications, 377 citations, selected as emerging leader in international infectious disease by ISID in 2022, received Bill and Melinda Gates Foundation grant at ICID 2024, Cape Town. He diagnosed the first case of Zika virus in Kerala and identified the Zika virus outbreak. Welcome, man.
Thank you. Good evening, all. Thank you, Calicut Surgical Club, and thank you, Dinlal, especially for inviting me. It's an honor to be here. So the topic is antibiotic myths in surgery. So we are talking about antibiotics. Why are we talking about antibiotics? So we are at a crisis here. This is something that we all know. We are losing our antibiotics. The bacteria are becoming more and more resistant. The bacteria that are isolated from various clinical samples, we find that they are resistant to the routine antibiotics that we use. Or even the high-end antibiotics like carbapenem are now become useless. I just want to show an example, or like what is the current state of antibiotics. And the ICMR does the surveillance of the susceptibility of various antibiotics every year. And 2024 they released it. Now this is the susceptibility pattern of E. coli isolated from various samples in India. So the lower below, you can see those yellow as well as green is ciprofloxacin and ceftazidime. Ceftazidime, the third generation cephalosporin. You can see the susceptibility is around 20% or 30%. If you're like using these third generation cephalosporins or ciprofloxacin for a gram-negative infection, your chance of success is 30%. And if you look at the above, the other antibiotics like meropenem, imipenem, etc., even for them, it's just around 80%. And then you come to Klebsiella, you can see again the similar pattern for like ciprofloxacin, ceftazidime, etc. The susceptibility is around 30%. For carbapenems, even it is like 60%. Like the carbapenem susceptibility is only 60%, 70%. Which means like 30% of a gram-negative isolate may be resistant to these antibiotics even. So that's why we are discussing antibiotics. AMR is an issue. It's not an issue for the microbiologists. It's not just an issue for the infectious disease specialists. It's an issue for everybody, for surgeons especially. Without antibiotics, there is no modern surgery. So that is why we chose this topic, myths and antibiotic myths in surgery. I do not mean that every surgeon here is using, like, doing something against the evidences. I'm sure you must be following what is the evidence-based practices. And the only thing is that there can be certain evidences which I have found occasionally during my practice. So this may not be applicable to you. But these are like certain tendencies in general where we can make certain changes, and as a whole, we can all move towards certain scientific behaviors by which we can reduce the antibiotic resistance. I just want to start with this low-hanging fruit, like surgical antibiotic prophylaxis. This is something like we all give, like when every day, like our patients receive surgical antibiotics. And is it true that this is India? Now, I have already told that there is antibiotic resistance, like a lot of antibiotic resistance in India. So the Western guidelines will say, like, you use first generation cephalosporin, cefazolin, cefuroxime. That won't work here. Well, is it a myth or is it truth? Now, when you're dealing with surgeries, the surgery is like, I don't want to explain this to a surgeon's group. Like, you know that the surgical wounds are like classified as clean surgeries, clean contaminated surgeries, and then you have contaminated wounds and dirty wounds. Now, surgical antibiotics are used, like antibiotics are used in all these situations. But when you're using antibiotics for a clean surgery or a clean contaminated surgery, you are using it as a prophylactic antibiotics. For 3 and 4, there is a contaminated and dirty wounds, where usually you are using antibiotics as treatment. Here it is not prophylaxis. Now, when you are using antibiotic for a clean surgery, what are the organisms that you are covering? Here the main issue is the organisms that are located in the skin. And in the skin, it is predominantly the skin flora. Now, the skin flora is predominantly the streptococcal species, Staphylococcus aureus, and the coagulase negative staphylococci. Now, for these organisms, the antibiotics choice are the first generation cephalosporin, that is cefazolin or cefuroxime. There is no need to go for a third generation cephalosporin, ceftriaxone, or cephalosporin sulbactam or piperacillin tazobactam as a prophylactic antibiotic in such situations. In fact, the third generation cephalosporin may be inferior to the first generation cephalosporin like cefazolin for the treatment of the gram-positive organisms. In fact, you may be increasing the risk of surgical site infection if you're using antibiotics like ceftriaxone or cephalosporin sulbactam for a clean surgery. If you're using it for a clean contaminated procedure, for example, an abdominal procedure, maybe a colorectal procedure, there you have a predominant organisms to be the gram-negative rods and enterococci. Western guidelines may say ceftriaxone, metronidazole, but here you may be even justified in using an antibiotic like cefoperazone sulbactam because of the resistance. So what is important is that every institute should have a surgical antibiotic policy which has to be adhered to and which has to be evidence-based for all the clean surgeries, first generation, or to the maximum you can use second generation. Why? Because like the first generation cephalosporins are very used so infrequently. Companies are actually good companies are not manufacturing cefazolin anymore. So we have to depend upon, even Sun has stopped Reflin, I think, they don't manufacture Reflin anymore. So that's the situation. So we don't get Reflin these days. So we are in our hospital, we are forced to use cefuroxime where we get some good brands. So this is our surgical antibiotic policy. So every surgery that is done in your institute should have a policy, and this policy should be adhered to. That is very important. So for all the clean surgeries like hernia surgeries and all the orthopedic procedures, CABGs, cefazolin or cefuroxime is good enough for the surgical antibiotic prophylaxis. And for all of them, majority of them, a single antibiotic is what is required as a surgical antibiotic prophylaxis, and no antibiotic is required after the closure of the skin. If you have procedures like the colorectal procedures I have already told, there is a risk of gram-negative infection. Sometimes can be cephalosporin, like third generation cephalosporin resistant. So we use cefoperazone sulbactam in our hospital as the surgical antibiotic procedure. For all rest, you can see like neurosurgery procedures, CTVS procedures, orthopedic procedures, joint replacement, all we use cefazolin or cefuroxime. In cases where we are using a prosthetic material, like a valve replacement or a knee joint processor, there is a TKR, we screen them for MRSA colonization. If they are colonized with MRSA, we give them a decolonization protocol for 7 days. And in the surgical antibiotic prophylaxis, we also include vancomycin in that situation, if they are proven to be MRSA colonized. So it's a good practice that you screen for MRSA. We have techniques by which you can screen for MRSA and decide whether they require vancomycin for this patient or not. And vancomycin is not to be used routinely for every patient. The ideal time for surgical antibiotic prophylaxis will be within 60 minutes. The ideal time will be 30 to 60 minutes before the surgical incision, so that when you put the incision, there is an adequate level of the antibiotic in the blood. And if you're using antibiotic vancomycin, as I already told, in special situations where you're using a device like a knee prosthesis or a valve replacement, and it's an MRSA colonized patient, in that situation we may have to use vancomycin. You start vancomycin 2 hours prior to the procedures, because vancomycin has to be given as a 1 hour infusion. So by the time, if you need the levels to be there before the skin incision is made, this 1 hour infusion, then you have another 60 minutes to go. So it has to be started 120 minutes prior to the surgical incision. And is redosing required? Redosing is required if the procedure duration is more than 2 half-life of the antibiotics that you're using. For example, if cefazolin and cefuroxime, the T-half is 1.5 to 2 hours, which means that if it is going more than 4 hours, you may have to redose it. For vancomycin, the T-half is 4 to 8 hours, because in most of the surgeries, we don't have to redose vancomycin. Again, if you have excessive blood loss, that is more than 1,500 ml, then you have to redose it again. And some special situations like extensive burns, etc., where you may have the half-life of the antibiotic may be shortened, you may need to redose it again. You have to be careful when you're redosing in patients who have a renal impairment. And again, the duration of surgical antibiotic prophylaxis, if you're using it as a prophylaxis, it's a single dose, and no dose should be used after skin closure. In cardiothoracic procedures, like prophylactic duration up to 24 to 48 hours has been accepted, though it remains controversial in terms of evidence. So that is it, regarding surgical antibiotic prophylaxis. Now, something that we occasionally hear the surgeon say is that the drain isn't removed, it is still there, let us not stop the antibiotics. There is no data to support that the continuation of antibiotic prophylaxis should be done just because there is an indwelling drain or intravascular catheter. So that is not an explanation for continuing the antibiotics. All said and done, is it religiously followed? I told that, this has to be followed. There should not be any antibiotic after surgical closure. It may not be, even our institute, but it may not be completely followed. But you have to keep on auditing. There should be a team that audit the surgical antibiotic prophylaxis regularly. I think it's an NABH requirement also now. So we did, like, I mean, one of the surgeries that we didn't have like much of a complaints was colorectal surgeries. We didn't want to impose it very strictly because we know it's a surgery that sometimes can be associated with infection. But then the surgeons told that, let us see what happens if we stop antibiotics. There is no antibiotics to be given after the skin closure. So you can see that the distribution of surgeries and how many antibiotics given after the surgical prophylaxis. So this predominantly included our LARs, you have the hemicolectomy, sigmoidectomies, etc. So we told them to use the minimal antibiotics. What we found that there was no antibiotics given after the skin closure in around 11 patients. This is a 6 months data, and one antibiotic alone was given in 30 patients. So they reduce the number of antibiotics. So most of the patients receive no antibiotics after the skin closure, or at least at the maximum of one antibiotics in a significant number of patients. And we did not find any increase in the surgical site infections or any infectious complications. So similarly, audits has to be done. That will improve the confidence of the surgeon that even if you're not using any antibiotics after skin closure, this is not going to lead to any increase in the surgical site infections. And audits are important because we have to make sure that the surgeons are following the antibiotics in terms of the antibiotic choice, the duration of antibiotics, and the timing of the antibiotic. These three parameters has to be audited, and there should be special team for auditing this. So that's regarding surgical antibiotic prophylaxis. So I'll be jumping from one topic to the another. So the next topic is something different. If any comments or any queries at this point of time, we can take.
Hello. How about the use of prophylactic antibiotic routine surgical cases? I believe that the patient is immunosuppressed, immunocompromised, there's a need. Otherwise, a clean, healthy case without no compromise, gut microbiome working well, gut-brain axis working well, it doesn't require any prophylactic and routine surgery.
Absolutely. So for thyroidectomy, surgeries where you have good vasculature, in thyroidectomy and all, even if you don't give any antibiotics, it's fine actually.
The largest number of surgeries done is in MCH Calicut. I was before I joined KMCT. All open hernias, there was no antibiotic given, and most of the patients went off very well also.
Very good, sir.
There's no need for any prophylactic antibiotics. Healthy people who have no immunocompromise.
Same point, sir. Very good point, sir.
You are given antibiotics, prophylactic antibiotics for 2 doses actually. You will give a first dose and second dose actually. After 3 days, suppose the patient, the wound infected, what is your choice actually? The already given antibiotic or?
It totally depends upon what is your area of surgery, sir. If it is an abdomen, so abdomen means you are at risk of gram negatives. And for us, the gram negative means they are extended spectrum beta-lactam is producing, which means they will be resistant to third generation cephalosporin around 50 to 60%. So there the choice has to be in antibiotics that will cover these organisms. There you cannot use a ceftriaxone as the antibiotic choice. I will use at least cephalosporin sulbactam or piperacillin tazobactam there.
No, you have given cefazolin.
Yes.
As the prophylactic dose actually. After 2 days or 3 days, the wound will get infected. So will you give the cefazolin?
No, I won't use cefazolin again. That's just for
antibiotic.
the skin contaminant, the skin and bacteria that I'm using cefazolin. For infected wound, I won't use cefazolin. If it is proved that it is a methicillin sensitive Staphylococcus aureus, I will de-escalate to cefazolin. But as empirically, I'll never use cefazolin.
So the infection can be due to the skin flora.
It could be, but then you don't know if it is sensitive or not. So initially, it can be a broad cover, and then you can de-escalate.
Nice points. I think using antibiotic also depends upon the organisms related to individual institute. Of late, we are finding multi-drug resistant organism, and these are unlikely to respond to your prophylactic antibiotic. And recently, we saw 2-3 cases of multi-drug resistant E. coli. Surprisingly, we got one antibiotic sensitive, TG-cycline. So prophylactic antibiotic policy depends upon many factors. If you cannot guarantee the sterilization, because in most of the, at least in government centers, there must be in multiple cases done, maybe hernia or anything, and the instrument sterilization policy may not be proper. So we cannot blankly say antibiotic is not needed if it's a clean hernia surgery, and we cannot assure the sterility of instruments in some situation. Okay.
Yes. Every institute should have its own policy. That's very important. And institutional antibiogram is something that I want to stress, and which has to be followed to and adhered to. So I'll move to the next. It's a clinical case.
I was just worried about that slide in that that colorectal surgery you specifically chose for single dose of antibiotic and no antibiotic after. Was there any change made depending on the intra-op contamination or fecal contamination?
They did. Like some of them used extra antibiotics. Like the nil antibiotics or one antibiotics was only like for majority of the cases.
Why the one antibiotic? What is that one antibiotic means?
The surgeons like no, like it is, even if you say that, the surgeons sometimes give it. So it's like we recommend that it should not be given.
It's
but
just
sometimes
a retrospective data.
Yeah, it's a retrospective data. Like see, like we suggest these things, but it is not that they will be followed to the word. So the point is that you have to audit it, and when you give this data, they'll become more and more confident and will be like not be using much antibiotics. So next is a simple case. A 32-year-old man presents with a 3.5 centimeter fluctuant abscess on the thigh with surrounding erythema. His afebrile hemodynamic stable, no diabetes immunosuppression. Abscess is incised and drained. So this is the antibiotic culture reports. Like basically it's the Staphylococcus aureus. So it's cloxacillin resistant. It's sensitive to Septran, that is trimethoprene sulfamethoxazole, tetracycline sensitive, but clindamycin resistant, and sensitive to linezolid and vancomycin. So I would ask the PGs if is it true that it's MRSA and linezolid is the only oral option that you have? Or what antibiotics will you use for this patient who has So if the size is less than 2 centimeter and you do an IND and there is no features of sepsis and all, you need not even give antibiotics. But the point is that linezolid is kind of a reserve antibiotic. Linezolid is an antibiotic that is used in tuberculosis. It's not a simple antibiotic. It's not an antibiotic that used to be used in every patient. And it has to be carefully used. The point I want to make is that for MRSA, there are multiple options, oral options. It's not just linezolid. Here, the antibiotics that very infrequently that we use is one of the best antibiotics that we have. The best antibiotics means in terms of tissue penetration, Septran, that is trimethoprene sulfamethoxazole. So such patients, trimethoprene sulfamethoxazole will be an excellent antibiotic, even if it's an MRSA, but it has to be found to be susceptible. You have to prove it to be susceptible. Similarly, tetracycline. If it is tetracycline sensitive, you can extrapolate that it will be sensitive to doxycycline and minocycline. So that will be the alternate options as well. So every MRSA treatment, like where you require an oral option, linezolid is not the only option. Preserve linezolid, it should be your last option. You have better options like Septran, you have doxycycline, minocycline, etc. This is our antibiotic susceptibility to the Staphylococcus isolates from our hospital. So you can see there is significant MRSA, if it is cloxacillin resistant. So for the PGs again, so how do you know that it's an MRSA? So it's written as cloxacillin resistant. So if it's resistant to any staphylococcal, anti-staphylococcal penicillin, you can call it as MRSA. So methicillin resistance is equal to cloxacillin resistant. So cloxacillin resistant also means MRSA. So that's how we interpret it as MRSA. So this is our antibiogram. So all the organisms are susceptible to dapto, vanco, tico, and linit. But after that, tetracycline also there is significant susceptibility, around 90%. Cotrimoxazole, it is around 60 to 70% susceptibility is there. So there, again, I think we can use Septran, but it has to be proven susceptible because the resistant rate is high. And you may be worried about the Stevens-Johnson syndrome and all those things, but it is very rare. But then you have to tell the patient, there is this risk. You have to take an allergy history, document that the patient do not have sulfa allergy, and document that in case of any rash, stop the medicine immediately and return back. So because of the allergy fear, Septran unfortunately has become a drug that is very infrequently used, but it is a very good antibiotic for all the purposes. Be it MRSA, even for UTI, acute cystitis, it's an excellent antibiotic. So continue to use the old antibiotics where they can be used and preserve the newer one with the broader spectrum for specific situation. Next is also a clinical case. A 15-year-old boy with 5-day history of fever and rapidly progressive right lower lip swelling. Spreading cellulitis, trismus, odynophagia, and dysphagia. A CT neck is showing a diffuse edema of the floor of the mouth with bilateral submandibular deep tissue edema. There is severe cellulitis, a possible necrotizing infection, but it's not drainable abscess. And the lungs also, there is multiple subpleural parenchymal nodules suggestive of a septic embolization. His initial blood cultures grew GPC, and from the surgery side, he was started on piperacillin tazobactam and vancomycin. So this is a necrotizing infection involving the lip. And you can see there is a cavitating lesion in the lung, which is a septic emboli. Now this is the blood culture. So it is Staphylococcus aureus again. So what is the difference here? It's cloxacillin sensitive, so it's MSSA. So how will you proceed? So will you continue piptaz and vancomycin? You stop piptaz, continue vancomycin alone. Stop piptaz, vanco, and add cefazolin. So the point to be made is that for MSSA, that is methicillin sensitive Staphylococcus aureus, severe infections including bacteremias, the antibiotics of choice is either an anti-staphylococcal penicillin, that is cloxacillin, flucloxacillin, etc. Equally effective is first generation cephalosporin, that is cefazolin. Vancomycin is inferior to the treatment of MSSA. It is inferior to cefazolin for the treatment of MSSA. That is the point I want to drive. So you can see here, it is sensitive to cloxacillin, so it's an MSSA. And the regimen, but you may ask me, like, cefazolin is not given here, but then you have to interpret here. If it is MSSA, cefazolin will work. It has been proven in RCTs. Cloxacillin and cefazolin are almost equal. Cefazolin is non-inferior to cloxacillin as well. So here, the correct answer will be stop piperacillin tazobactam, vancomycin, and add cefazolin. Any comments? Yeah, cefuroxime is a second generation cephalosporin. The thing is that as the generation goes upwards, the gram-positive cover decreases and the gram-negative cover better. So the first choice will be the first generation cephalosporin. That is cefazolin will be the choice. Cefuroxime will cover MSSA, but it's not as good as cefazolin. It can be given. IV cloxacillin can be given. As I told, alternate will be. The problem with IV cloxacillin is that it will have to be given as a 6-hourly dosing, and there is an increased incidence of phlebitis. So there is a very recent trial. So that's why everybody wants to change to cefazolin. But we are not very sure that cefazolin is actually equally good as cloxacillin. So especially in high inoculum infections, where there is a high bacterial load, like an endocarditis, people were concerned that it may not be as good as cloxacillin. And very recently, 2 months back, there is a new trial which is published, called as a CLOSIBA trial, where they compared cefazolin to cloxacillin and found that cefazolin is non-inferior to cloxacillin. There's one more trial that we are waiting, that's called the SNAP trial, which is a larger trial comparing cloxacillin and cefazolin, and we hope that it is the same result that is going to come. So until then, cefazolin is equal to cloxacillin for the treatment of MSS. For this clinical syndrome, I would not suspect any other organism. Staphylococcus aureus, this is a typical clinical syndrome it can present with. So you cannot, always think that there can be multiple organisms and use broad spectrum. It is floor of mouth swelling, but you have a Staph aureus in blood. I won't think anything else. Yes, this is a blood culture. Yeah, so oral antibiotics options will be cefalexin, again it's the first generation cephalosporin, dicloxacillin, anti-staphylococcal penicillin. Then all the antibiotics that I have told for MRS, Septran, doxycycline, minocycline, everything will work. But for them you have to prove the susceptibility. But if it is MSSA, cefalexin, you can use it. Even if the susceptibility is not mentioned, you can use cefalexin. Dicloxacillin you can use. No, sir. Chloramphenicol, we don't use it as a routine antibiotic for staphylococcal infections. It's not vanished. It's still there. The only situation where we use it is resistant. Sometimes for enteric fever and all, we used to use it in medical college, but it's very difficult to get. And then you have the side effect of agranulocytosis, by which it is not. We sometimes find gram-negative isolates, which is only sensitive to chloramphenicol, but then it's very hard to get it. Yes. Yes, like once susceptibility is proven, the old drug, there is nothing that there's no difference between the old and new. It all depends upon the susceptibility of the organisms. And there is no antibiotics as of now that we have which is as good as the beta-lactam antibiotics or quinolone antibiotics. All these antibiotics like polymyxin, tigecycline, etc., are quite inferior to the beta-lactams. They may have, they may be they may be the only antibiotic that can be used based upon the susceptibility. But when you're comparing between these antibiotics, these new antibiotics like tigecycline, polymyxin, etc., are much inferior to the beta-lactam antibiotics. So next is the 56-year-old male with uncontrolled diabetes presenting with complaints of fever associated with pain and swelling in the left lower limb. On examination, the right lower limb was swollen and tense passive movement causing excruciating pain. Heart rate was 130 per minute, BP was 90/60. You can see it's a necrotizing infection. The counts was high, hemoglobin was 12.1, creatinine was slightly raised. So there is no question here. I just want to touch upon this particular clinical symptom, that is necrotizing fasciitis, a common clinical symptom that we come across. So necrotizing clinical fasciitis is divided into type 1 and type 2 necrotizing fasciitis. Type 2 is the monomicrobial infection. So the monomicrobial, it is usually caused by Streptococcus pyogenes. It remains Streptococcus pyogenes in even our setting, sometimes caused by MRSA, Vibrio vulnificus, etc. On the other hand, necrotizing fasciitis 2 commonly occurs in diabetic patients and immunocompromised patients, and it is usually caused by polymicrobial infections comprising of enterobacterials, bacteroids, Clostridium, and Streptococcus species. So how do you treat cases of necrotizing fasciitis? So there are various guidelines. So basically, when a patient is coming with necrotizing fasciitis, you may not be able to tell it's type 1 or type 2. And if the patient is in shock, it is better that you cover for all. So it can sometimes in immunocompromised diabetic, etc., it can even be the gram negatives. So we'll have to cover for the gram negatives as well. So carbapenem or piperacillin tazobactam has to be used. Sometimes it can be MRSA. For covering an MRSA serious infection, where there can be even bacteremia, you may use vancomycin or daptomycin. You may have to use, even if you are using vancomycin or daptomycin, clindamycin still have to be added. Clindamycin is added not for the bacteria to be killed, it is added for its antitoxin effect. So this is the various guidelines where they say. We usually follow the last one, the up-to-date guideline. If a patient comes with shock, usually give a combination of carbapenem, vancomycin, or ticoplanin. Ticoplanin is almost equivalent to vancomycin for that matter. And we also give clindamycin. A higher dose of clindamycin is usually recommended. 900 milligrams 8th hourly is the dose that you give for shock. And usually it's the shock, like for clindamycin, we continue it's usually until the patient becomes hemodynamically stable and the shock resolves. After that, we usually stop clindamycin. So Streptococcus pyogenes, like this remains a major cause of the type 2 necrotizing fasciitis. So this is our data published in IGCCM. So it remains susceptible to penicillin, as I was told already. This particular bacteria remains sensitive to penicillin and ceftriaxone, 100% susceptibility is there. So it has been proved that the organism that is causing necrotizing fasciitis is Streptococcus pyogenes. You can use penicillin if it is available. Unfortunately, good brands of crystalline penicillin is difficult to get in our setting. But if you can get a good penicillin brand, it is still the drug of choice for streptococcal pyogenes infection. Clindamycin, you can see that the susceptibility is around 60 to 70%. So clindamycin should not be used as a monotherapy for the treatment of Streptococcus pyogenes infection. But still, we use clindamycin in these situations. So why do you use clindamycin? As I've already told, it suppresses the streptococcal toxin and cytokine production. But always penicillin or ceftriaxone should be added to the treatment because of the potential resistance. There is this debate that is going on. Should linezolid should replace clindamycin as the adjunctive antimicrobial of choice in group S streptococcal necrotizing soft tissue infection and toxic shock syndrome? So basically, linezolid is also a protein synthesis inhibitor. It can also block the toxin production. So whether we should change clindamycin and replace it with linezolid. So it's a debate that is ongoing. So basically, there are points for clindamycin, there are points for linezolid as well. So as of now, what is the final conclusion is that the maximum evidence for using as an antitoxin effect is still clindamycin. And the recommendation is to continue with clindamycin as of now and not to replace it with linezolid. I'm not going to the details of the comparison. Now, the other question is that will antitoxin effect be preserved if clindamycin is resistant? So you have a necrotizing infection due to Streptococcus pyogenes, and the culture grew Streptococcus pyogenes. It's sensitive to penicillin but resistant to clinda. And the patient has shock. So will you continue clinda? You can continue clinda. Irrespective of its sensitivity, its antitoxin action remains. This is from limited evidence from 2 observational studies, but you can continue clindamycin until the shock resolved. And any patient who is having toxic shock syndrome due to Streptococcus pyogenes infection, there is a role for intravenous immunoglobulin also. So IVIG should be used as an adjunctive agent. There is a meta-analysis which was done, which has shown there is a role for intravenous immunoglobulin also for the treatment of necrotizing fasciitis. I mean, apart from surgery, I have not mentioned the surgery. It's always mentioned that the scalpel is the best antibody for necrotizing infection. The first thing that you have to do is surgery. This is just touching upon the antibiotic part. Any comments? So now another topic. How many of you use meropenem sulbactam? Very good. So there are a lot of antibiotics unfortunately approved in the country which are irrational and should not be used. A lot of combinations approved by the government, but unfortunately these are antibiotics which do not have rationality in their combination. And when you have an antibiotics, the laboratory should tell you whether it is sensitive or resistant. So the laboratory depends upon certain recommendation by certain bodies. These bodies are called as the CLSI, UCAST and all. So for many of these combinations, such cutoffs doesn't occur. I mean, there are no cutoffs. So then how do you decide whether these are sensitive or not? So they should not be used. The ICMR recently had a publication from the ICMR group where they told that these antibiotics should not be used for the treatment of the gram-negative infection. That's the ESBL infection. So you can read it: ceftriaxone sulbactam, ceftazidime tazobactam, ceftriaxone sulbactam, okay, that's already mentioned, cefotaxime sulbactam, ceftazidime tazobactam, meropenem sulbactam, ceftriaxone EDTA sulbactam, cefoperazone tazobactam, and cefepime sulbactam. So none of them should not be used. So do not confuse it with the approved one. There are approved one. For example, ceftazidime avibactam is a new antibiotic which is an approved one which is used for carbapenem resistant infection. Now, there is a new antibiotics which is an Indian research molecule proven in clinical trials, approved by the US FDA, that is cefepime N-metazobactam, CIP and MET, which is also approved. So, but do not think that all the combination that comes to you are actually rational or can be used. There are many of them which cannot be used and for which there is no breakpoints available to tell whether these antibiotics are susceptible or not. Then regarding the ciprofloxacin is an antibiotic which is often used for various situations like wound infections empirically, UTA empirically. As I've already told that this antibiotics has a problem because the resistance is too high. So this is our own data from blood cultures, and majority of the source was urine isolate. So you can see that the ciprofloxacin is a third one. The susceptibility is around 25%. So empirically using ciprofloxacin to target a gram-negative infection, you're going to fail 3 out of the 4 times that you're using these antibiotics. So that is what you have to remember. So if it is a proven infection, okay, you can use it. It's a proven infection due to Pseudomonas aeruginosa, is susceptible to ciprofloxacin, you can use it. But then empirically using it for wound infections, etc., is not a good choice. Even for urinary tract infection, its susceptibility is less than 50%. If you're using it for cystitis, half of the time you're going to fail. So do not use ciprofloxacin empirically. These are good, it's a very good antibiotic, it's proven susceptible, it has, it's a very wonderful antibiotic, it will work well. Susceptibility has to be proven. Empirical quinolone use should not be encouraged. So next one, conversation. So this patient is on piperacillin tazobactam for a perforated appendix. Add metronidazole for anaerobic cover. Now I think this has been told many times that everybody has got this point. So piperacillin tazobactam, cefoperazone sulbactam, amoxicillin clavulinate, and the carbapenems. The carbapenem means meropenem, imipenem, and ertapenem by themselves have enough anaerobic cover. There is no need to add an additional clindamycin or metronidazole to these agents for an additional anaerobic cover. So dual anaerobic cover should not be encouraged. There is no indication. Okay. And finally, allergies. This is a common thing that you get. Like whenever you are planning for a surgery, a surgical antibiotic prophylaxis, the patient comes with a list and resistant to everything, penicillin, clindamycin, ciprofloxacin, and somebody would have done an allergy test somewhere outside. Usually, pulmonologists do that. Is there any validity for this particular test? There is no validity for skin testing of antibiotics as such, like for the majority of the antibiotics, except for the beta-lactams. There is no validity, like ciprofloxacin, clindamycin, all those antibiotics should not, like skin testing should not be done. Even for the beta-lactams, the skin testing should be done with a specific agent. So this is called as a penicillin oil agent, which is not available in India. So even the skin testing that you're doing for penicillin, ceftriaxone, etc., even these are actually not validated, and these actually cannot predict whether the patient develop allergy or not. So skin testing for majority of the antibiotics is unscientific and not validated. We do not do skin testing for any antibiotic except benzathine penicillin in our hospital for the last maybe 15 years, and we have not come across any problems. But still we see a lot of patients who come with penicillin allergy, like they say that the patient is allergic to penicillin and you cannot use it. And you can use various scoring systems by which whether you can know whether the patient's allergy is a high risk or a low risk. So this is called as the PEN-FAST scoring system, by which you can see whether the allergic risk is low or high. So if 5 years is passed since the last reaction, you have a score of 2. Anaphylaxis, angioedema or scars, you have a score of 2. And treatment required for allergy 1. If the score, if you combine the score of take a history and combine the score of this patient, and you get a score of 0, it's a very low risk. And if the score is 1 to 2, it is low risk. And more than that, it's moderate to high risk. And so what is, I told you that you don't have an agent by which you can test for the penicillin allergy. So in such situations, like very low risk and low risk, instead of giving penicillin intradermally, you can also use an oral challenge. You can use oral amoxicillin, give to the patient, and watch for any allergic reactions. So we looked at patients who have reported beta-lactam allergy. They told that self-reported beta-lactam allergy. So how many of these patients actually were low risk and could be given an oral challenge? And we found that just by history, by the PEN-FAST scoring system, another scoring system called the CEF-FAST scoring system, 51% of these patients were actually low risk, and you can give an oral challenge, and we can actually delabel these patients by doing an oral challenge. So amoxicillin oral challenge is basically you give a full dose of amoxicillin and wait for 1 hour, and you see if there is any response, any allergic response. This has to be done in the ER where there is every setup for managing an anaphylactic reaction. And graded amoxicillin challenge is given for higher risk patients. You give 1/4 of the dose, and you observe for 30 to 60 minutes. And if there is no allergy, you give the full dose and then again observe for 30 to 60 minutes. Because this problem has become so problematic for us, so we have started a penicillin allergy delabeling clinic in our infectious diseases OPD. So where the patients will come and we take the history and delabel them straightly or give them an oral challenge and delabel them later. So the thing is that every patient who comes to you with a history, telling that they have an allergy to antibiotics may not be true. Take a proper history. So what sometimes they may be telling us allergy may be some vomiting, some nausea and all. Even these people call it as allergy. So you can directly delabel them. They are not allergies. And for cases of mild reactions, mild maculopapular reactions, etc., you can use a PEN-FAST scoring system and then decide whether you have to go with the oral challenge or not. So these were the topics that I wanted to discuss. So antibiotic stewardship means basically the judicious use of antibiotics. So as your patient in front of you get the maximum benefit, and the future generations, they are not devoid of antibiotics in the future as well. So we have to protect the antibiotics for the future generations as well. So there are few steps which can be taken. These are called as low-hanging fruits, means these are simple steps by which we can improve the antibiotic use in every hospital. First thing is that every hospital should have a hospital antibiogram. Whatever is the clinical syndrome, what were the organisms that were isolated from these clinical syndromes, and what are the susceptibilities. That should be there. And institute-specific data should be used to guide the empiric therapy to reduce the blind broad-spectrum use in every institute. And every institute should have a clear surgical antibiotic prophylaxis, and this has to be adhered to in terms of the choice of the antibiotics, timing of the antibiotic, and duration of the antibiotic. And this has to be periodically audited, and the surgeons has to be given feedbacks. And eliminate irrational antibiotic combination from the formula. It has to be removed. Nobody should be able to write the antibiotics that I've mentioned. Our hospital, like, these antibiotics are not there, and nobody is allowed to buy from outside as well. Anyway, so stop dual antibiotic cover. That is something, again, easily you can implement in a institute, and use antibiotics like linezolid and quinolones very judiciously, only for indicated cases. So surgery has moved a long way, like from this to this. You can see, like, from the archaic things to robotic surgery. So, like, technology has improved, everything has improved. And so our antibiotic usage also has to evolve as the evidence comes. So we have to submit to the evidence, like whatever we have practiced. We may have practiced many things before, but as new evidences come, we have to submit to evidence, and that is what is the practice of evidence-based medicine. Thank you all once again for inviting me.
Hello. Topic is open.
It's a good topic. I just want to know whether the skin test that is routinely being done in hospitals and elsewhere, according to you, that this is not necessary.
It is not validated. Now, the
so
problem that is going to be raised is, what about the legal issues?
That's what I'm saying.
I know. Unfortunately, even doctors do not know that. So that is the issue. Like, so we are trying to raise it as a issue, like the Clinical Infectious Disease Society, to the government and all. It's an invalidated practice for most of the antibiotics, and especially for the non-beta-lactam, it should not be done for sure. And for the others also, except for penicillin, I think it is not a good thing. So again, for penicillin, as I already told, if you're doing the penicillin intradermal challenge, there is a specific agent that is required, a penicilloyl moiety. You can do the challenge with that alone. Even that is not available in India. So if you want to do penicillin allergy, if you want to look for it, the only thing that is available, the best thing that is available is to do it with a crystalline penicillin. Even if you're giving benzathine penicillin, doing antibiotic challenge with benzathine penicillin is not recommended. You do the challenge with benzyl penicillin, that is crystalline penicillin.
Because we can't expect the results, by giving oral or any challenges, because the patients, they would become...
that issue is there, sir. Like, I understand. And something that has to come from various organizations, we have to deliberate. Like, there is something that is going on, and like, we try to make it, like, it has to come from the government so that legally we are protected. I totally accept that.
Another thing is that we...
It should not be done, ma'am. It is absolutely unscientific. In no other countries it's done.
Thank you, Dr. Nias, for the excellent presentation. You are very convincing presentation. So I just want to know, in your hospital where you work, were you able to convince the orthopedicians and the cardiothoracic surgeons?
Absolutely, sir. The not for the CTVS, for our joint replacement, that is the maximum this compliance with the timing, duration, as well as the timing of antibiotics is for our TKRs. Excellent compliance. And Dr. Nasir, you can, I can vouch for that. CTVS continuous antibiotics. Yeah. CTVS and continuous antibiotics for that is why for them we have put it as 48 hours. It's not 1 day, like 2 days. So that occurs because CTVS, the problem is that the patient becomes sick. Sometimes you don't know the patient is infection or not, what is happening. So every CTVS patient is a problem. And, but still we have almost 100% compliance with the choice. They only use cefuroxime. They continue it for maybe 5 days, that is true.
Yeah. One thing is, we've been trying to convince these two groups, and then they always say, okay, we'll do that, but if the patient gets an infection, you should take the responsibility.
Yeah. That is why ID should be, so we'll take care. We take care of the infections.
Yeah. Then just a question, there's one board kept here, what about this drug?
All right, so since it is asked, I have to answer. Like, some representatives are there, I'm sorry. Ferropanam is not a carbapenem. It cannot be used as an oral step down for carbapenems. It has been used and tried only in UTIs in Japan. There is no trials for other infections. I'll stop with that because there are responses. Thank you. Any other question?
It has been an eye-opener for me. I am still in old practice. So you told that Ciplox is not used. So what other we will prescribe when patient?
See, what is a clinical syndrome? If you are like when a clinical syndrome is the patient is a UTI, a cystitis, so there is nitrofurantoin will be the drug of choice. If a patient is presenting with urinary tract infection and fever, you don't have oral options. You have to give IV, cefoperazone, Selbactam.
So if it is an UTI, mostly we prescribe everything for Ciplox only. So it will have to change to nitrofurantoin.
If it's cystitis, clinically cystitis means the patient won't have fever. They will have dysuria, increased frequency, and then you diagnose the cystitis. The drug of choice is nitrofurantoin. More than 90% is susceptible. 100 milligram BD for 7 days. If the patient has fever, clinically you have to take it as pyelonephritis. Nitrofurantoin will not work. There you only have IV options.
Okay. Then one more two questions. Most of the antibiotic report they have some additional column in MIC.
Yeah.
Do we clinically have any?
It has role, but not for general practice. If they put it as susceptible, it is okay. So it occurs like when you are using it for special situations, like sometimes you have to use carbapenem, even if it is carbapenem resistant and all. You can use carbapenem up to an MIC of like 16 and all. You can increase the dose to high dose and give continuous infusion and sometimes overcome the resistance. But that's not for routine practice. And then you cannot compare the MIC of two antibiotics. Okay, like in this thing, like the MIC of one antibiotic will be low and the other one is high. It is not that. It is, you can compare between the, like it's not to compare between the antibiotics. It is just if you can use that antibiotics by increasing the dose or anything like that.
And finally, one more thing. When the patient got bad, we tend to add antifungals. Is there any?
Again, clinical syndromes, sir. Basically, what is the situation? So, fungal infections, there are certain risk factors. A patient who is neutropenic, obviously the patient is in sepsis and hypotension, and the patient is neutropenic. You add antifungals, and there you start like with the caspofungin. There is no issue. But for every like patient getting bad, like adding antifungals is not going to help. And what are you adding? Like fluconazole, like 70% of our isolates are already azole resistant. So you are adding caspofungin for every patient, but that's not also not. Surgical patients who are abdominal surgeries, again at risk of fungal infection, that is candida. Candida infection. We're talking about candida alone here. You may add. But empirically, I'm adding antifungal for a patient who has risk factors. The antifungal of choice will be echinocandins, not fluconazole.
This is not about prophylaxis. If you get an accidental situation of some multi-drug resistant organism which is susceptible to one particular antibiotic and we continue it for say 10 days. So patient was okay. When we stop for 3 days, the 4th day patient again develop infection. So in those situations, what is the appropriate duration you have to?
Individualize, sir. Basically, you'll have to individualize it. If the source is controlled for an abdominal infection.
Most of the time the situation happens where we cannot control the source
You continue
fully.
it, sir. You'll have to continue long time. There is no, like, if there is an ongoing infection and all, we ask the surgeon, are you comfortable with, we only decide on the antibiotic. Are you comfortable with the source control? We stop it there. Like we ask the surgeon.
Regarding the use of topical antibiotic ointments and all, what is your opinion on?
Majority of it is, and there is not much of a scientific evidence. Like a smaller infection, less than 2 centimeter and all, you may apply it. But other than that, I don't think so.
What is the role of metronidazole in current day practice? Only for?
It depends upon if you're using ceftriaxone. It does not have good anaerobic cover. So ceftriaxone and metronidazole is a logical choice. But cefoperazone Selbactam with metronidazole is a redundant coverage.
So what is the antibiotic for burns wound?
Burns again will depend. So burns, majority of the burns, initially itself there is no need to cover with antibiotics as prophylactically. But then later, after 1 week and all, there is both risk for Pseudomonas aeruginosa as well as staphylococcal infections. So late wounds, I would cover with an antibiotics that cover Pseudomonas. So piperacillin. So Pseudomonas cover comes from the 3rd generation cephalosporin. So for us, cefoperazone Selbactam has Pseudomonas cover. Piperacillin Tazobactam has Pseudomonas cover. So many of this. But then Candida can also come in burns. So you have to watch for Candida as well. I also want to tell that MDR infections are at high. So you may get Klebsiella pneumonia which are resistant to everything with tigecycline. But then tigecycline will not be the drug of choice there. You have to look for the newer beta-lactamase inhibitor like ceftazidime avibactam, or a combination of ceftazidime avibactam with aztreonam. So ceftazidime avibactam with aztreonam, as of now, there is no isolate in India of Klebsiella pneumonia which are resistant to a combination of ceftazidime avibactam with aztreonam. So you can use a combination of ceftazidime avibactam with aztreonam, or there is a new drug which is come which is called as aztreonam avibactam. So that can also be used. But this does not hold good for E. coli. 1/3 of our E. coli isolate may be even resistant to this combination.
So what about bottom surgeries? Bottom surgeries like hemorrhoid and fistula.
What do you want to cover there? Like
No.
negatives?
Every day patient is, wound is contaminated with fecal matter. So
Yeah, so
whether
it's
we can continue the antibiotics for how long?
Surgeon decides.
Okay.
Like it.
Thank you.
What is it's not a clean surgery. You can call it as a contaminated surgery. So it's not prophylaxis. You'll have to treat the infected hemorrhoids.
Thank you, Niyas, for wonderful speech. So I have been thinking that our senior most members in the club have invaluable experiences to share with us. So experiences that could reshape our perspective on the profession and refine our approach to surgery, especially in decision making and communication with patients and bystanders. With this in mind, the plan is to organize a session every alternate month titled Moments of Pride and Lessons of Pain. There will be no need for a PowerPoint presentation. Instead of, we want to hear their stories directly. These real life insights can help us elevate the quality of our professional practice. After all, we don't always have to learn from our own mistakes. Learning from the experiences of the others is equally powerful. A 10-minute talk from them may give us an essence of 30 years of experience. So we got an ideal person to inaugurate this series of events. Welcome Santosh sir for the talk.
Good evening, everyone. Thank you for inviting me for this so-called inaugural exposition of ignorance. I'll just share due apologies to my senior colleagues here, Professor Madhavan Nambiar sir, Rajan sir, Vijay Kumar sir, Joji Malekil sir, and many people sitting in the audience. ചിലപ്പോൾ അഹങ്കാരമോ ചിലപ്പം അബദ്ധമോ ഒക്കെ ആയിരിക്കും പറയുന്നത്, എന്നാലും ക്ഷമിക്കുക. I'd like to share some moments of pride, പിന്നെ pain, അല്ലേ? Pride and pain. I would be very happy to share some moments of pride. Mohandas and me were almost contemporaries at Trivandrum Medical College, a few years difference. We worked in the same unit with Dr. P. A. Thomas when he was a final year MS student and I was a first year MS student. Soon after my MS, I was with Dr. Professor P. A. Thomas and I asked, sir, what should I do? So he said, I'll give you a letter to a surgeon by name Dr. Y.P. Abraham, who was chief of surgery at Pushpagiri Hospital. It was 27 kilometers away from Kottayam Medical College, and I started my surgical career there. One of the best surgeons I have ever met in my life, who has shaped my career and like the shape of many others in the state. So I'm going to tell a real incident when I was taking duty as post-MS. We were 5 post-MS people with him at that point of time, and I was the 5th in the line. I was never allowed, from the 3rd person onwards, nobody was allowed to take the independent duty. Bose and 2 other people will take the duty. The rest of them will not be allowed to take the duty. That was the scenario.
Fortunately or unfortunately, I got the chance to take the duty much ahead of the other two seniors in my department. So one of the weekends I was on duty. I came across a patient around 12 midnight when the call. And cell phone onnilla, intercom illa. I was staying outside. So attender will come with a small notebook where the sister will write, there is a patient admitted in ward 25. നമ്മൾ counter sign ചെയ്ത് കൊടുക്കണം. എന്നിട്ട് നമ്മൾ വണ്ടി ഓടിച്ച് അവിടെ പോയി കാണുക. This gentleman was there who was in a traffic accident. Traffic accident ഒരു സ്കൂട്ടർ മറിഞ്ഞു വീടും. പുള്ളിയും ഭാര്യയും ഉണ്ടായിരുന്നു. He sustained an injury, a small hairline fracture. He was not unconscious. So I said, just wait. By the by, the greatest investigation at that point of time was available was just a chest X-ray. And I'm sure that all of us were trained at the time when there was no ultrasound, no CT, no PET, no MRI and whatnot. So he had an injury here, a hairline crack. So I went back home. There was nothing to do. I went back home and around 2 o'clock in the morning I get a call stating that the patient is unconscious. So I came there. This was a weekend around Saturday late night. And he was unconscious. He had the typical Hutchinson's pupil. So naturally, clinically the suspicion was subdural hematoma, extradural hematoma. And he was told that he needs emergency decompression. So I said, I've not been trained in neurosurgery. I've just been seen only neurosurgery. So then this gentleman told me, after quite a while, they asked me what will happen, what should we do? I said, you go to Kottayam Medical College. What will happen? Probably you'll be shifted to Ernakulam for a CT scan. The CT scan has come at that point of time in the market. So what will happen? I said, I don't know. Anything can happen. So the next, after a little while, they said, can you operate? I said, I have only seen. I have not even assisted. So the name of my chief, Dr. Y.P. Abraham, was so, great in that society that these people decided that I should operate this patient. Incidentally, I was forced to operate. That was my first burr hole. And when I did the burr hole, there was no extradural hematoma. So it was converted into a craniotomy, and there was a big intracranial hematoma. We evacuated that. I evacuated that. By the time the chief joined me, the patient was put on a ventilator. And I must tell you that the first time I see a ventilator, there was no ventilator in Trivandrum Medical College. And that we used to put the patient on endotracheal tube and മലയാളത്തിൽ പറഞ്ഞാൽ ഇങ്ങനെ രാത്രി മുഴുവൻ PGs ബൈറ്റാണ് പീച്ചിക്കൊണ്ടിരിക്കുക. അതായിരുന്നു നമ്മുടെ വെന്റിലേഷൻ ആൻഡ് സസ്റ്റൈൻ. ഐ എം ഷുവർ ദറ്റ് സർ വിൽ അഗ്രി ടു മീ. ദീസ് വർ ദ ഡേയ്സ്. So this patient was put on a ventilator. This ventilator had only volume control, nothing else. So ഇതിനകത്തൊരു ഒരു ബട്ടണിൽ ഇങ്ങനെ ഞെക്കിക്കഴിഞ്ഞാൽ ഒരു ഗിയർ ഇങ്ങനെ ഇറങ്ങി വരും. ആ ഗിയറിന് ഇങ്ങനെ ബെവലുണ്ട്. അങ്ങനെ ആ ഗിയർ ഇട്ട് ഈ മെഷീനെ ഓടിച്ച 10 ബ്രത്ത് ഈ പേഷ്യൻറ്റിന് കൊടുക്കും. വേറൊരു ഗിയറുണ്ട്, അതിൽ ഇച്ചിരൂടെ സ്പീഡിൽ ഈ ബെവൽ പോവും. അതിട്ടടിച്ചാൽ 15 എണ്ണം കൊടുക്കും. വേറൊരു ഗിയറുണ്ട്, മൂന്നാമത്തെ ഗിയറിൽ ഈ പേഷ്യൻ്റ് ഇട്ടാൽ 20 എണ്ണം കൊടുക്കും. ഈ മൂന്ന് ഗിയറുണ്ട്, ഈ 3 റേറ്റിൽ ഇതും കൊടുക്കും. അത്രയേ ഉള്ളൂ ഈ സാധനത്തിൻ്റെ ഇത്. Fortunately, the patients are survived. I did few more during my tenure as a assistant to Dr. Y.P. Abraham in neurosurgery, but fortunately I'm here, having no training after that. And the last burr hole I have done was 35 years back. Why I tell this story is today, when you ask a surgical graduate about what you want to do in your life or what you do for this patient, suddenly you will get an answer that you will refer it to the cardiac surgeon, you will refer to the thoracic surgeon, you will refer to the neurosurgeon, you will refer to the urologist. So what are you going to do yourself? You hardly left with only an IND to do. So never ever, resist or never ever refuse to take a challenge in your life, because these challenges will make you better in taking up challenges later in your life. That was my first story. The second story is much, much later. It was an evening when I was just about to go for shuttle. I was in my trousers. I get a call from the casualty saying that there is a young girl who was involved in an accident. The bus fell down. നമ്മുടെ കണ്ടത്തിലേക്ക് ബസ് ഒരു 15 അടി താഴോട്ട് പോയി. And a lot of the people who were involved in the bus accident, they were all injured, but no great injury, abrasion, small contusion, hematoma, all kinds of things. So all these patients went to Moatuvuzha Taluk Hospital, and they all had their first aid treatment. There was one girl who had a penetrating injury onto the right chest, and that wound was closed because there was no air leak. That wound was closed. And a medical officer there, maybe treating this 50 or 60 patients there, he or some good nurse has noted that this lady has developing a tachycardia and a BP fall. And they promptly referred this patient. A good Samaritan who was traveling along with her took this patient and came to the casualty. When the casualty called me, the patient had severely, hardly palpable pulse and hardly recordable BP. And I examined the patient. She had a massive hemothorax on the right side. There is no bystander. There is no blood available. No consent available. Either I have the option to leave that patient alone for all these things to come in, or take the patient with a certain risk and bereavement of the family and operate, and legal system will be against me. So I decided that I will take the patient into the theater. We did a thoracotomy, and thoracotomy had massive blood. Patient hardly any BP. So how to give blood? That was the time when we thought about, we all talk about auto transfusion, etc. Do we have a sterile suction in our theater? We don't have. So how to give this? We had to use 20 ml and 10 ml syringes to take the blood. It was a pulmonary artery injury. I was keeping my 2 fingers onto the hilum. I didn't know what it is, and sucking out this blood and putting it in the blood bag. We transfused this lady 52 pints of blood taken from the chest and transfused back. All this blood had anticoagulated, and it had to be decalcified. Calcium had to be given massively. I don't think it will happen today. In my hospital, me being the medical superintendent, if I want to get even a single blood bag from the from the blood bank, the kind of information will get escalated. I work in a Catholic hospital, will go even up to the Pope probably before I can get a blood bag issued to the theater. I mean, that's probably the NABH and all those circumstances. You have a lot of impediment to the system. You need to get something done. The unfortunate part is this is the time when we realize that when you take this blood in this kind of condition, the blood, by putting it in the syringe, will clot by itself. And a syringe cannot have more than 4 or 5 times used. The 20 ml also, when you push it hard, you will have a hemolysis. So it had to be slow. Anyway, luckily, the patient survived. And the story goes, this girl is actually one of the 2 children a couple had. And mother tells me that the mother has a premonition at that point of time. And why the premonition was, her younger brother got electrocuted while owning the iron on the same day a year back. So it's all providence. My hands and my thoughts at that point of time was instrumental in giving back the family that live child. Patient walked out of the hospital on the 10th day, trust me. The third case I'm going to describe is again another interesting case. This is a guy who has fallen down from a bicycle, had a hit, a blunt injury, chest actually. He was admitted in the district hospital at Ernakulam. They promptly diagnosed a respiratory distress. massive pneumothorax. They have put a, I didn't see Sabbath, I saw you now. Sabbath was trained under me at DNB at Lutz. So this patient had a massive pneumothorax. The whole lung on the right side was just at the hilum. They put in a chest tube. Massive air leak came in, but the lung did not expand. They pulled out the tube, thinking that it is gone into the lung. They put another tube. The story remains the same. So they put, and with this thing, they decided that they will not do anything. They shifted the patient to us. And when I saw this patient, I again thought that the tube has gone into the chest. So I pulled out the tube and put another tube. No joy, it remains the same. I thought then we'll give one more tube which was put on the anterior. So that was my thought. One has gone from below to the fifth intercostal space as anybody else will do. I'll put one above anteriorly and see what benefit it does. It did not improve at all. Then I started thinking that why not we give some suction? So we put the patient onto some suction. The lung will not improve, lung will not come back. But the patient was more or less respiratory stable. I didn't want to open at that point of time. So we thought of increasing the suction and things like that. So by about 6th day, the patient started getting fever, counts were high, and there was a suggestion of a small pleural fluid in the recess. So I thought it's time to take a decision and take the patient to the theater. So I did a thoracotomy. The moment I opened the chest, the anesthetist said, I cannot bag this patient. The entire thing has completely gone. So what I saw was the trachea, the right main bronchus has actually avulsed from the trachea and it was hanging down. It was because of the closed space. The patient was sustaining this thing, the air was leaking, but the moment I opened the chest, there was nothing, entire thing was coming out. So I closed. So this is the first time I'm confronting such a situation. So I had to think myself, I just closed and I asked my assistant to keep it closed. Then I phoned up two people. One was Dr. Vettath, who was my senior colleague. He retired by that time. He was probably one of the first trained cardiac surgeons in the country. As you all know, he was trained in America, and later on he was professor of surgery at Ludhiana. When I called him, he said, Sir, Santosh, you best do a pneumonectomy. So just ligate the end of the trachea and at the bronchial level and do a pneumonectomy, which is easier. I was not very convinced that I should lose a vascularized lung just because it has lost its luminal continuity. The second person I called, that was Dr. T.M. Joseph, who was the man who has performed the first open heart surgery in Kerala. He was the chief of surgery at Medical Trust Hospital, Cochin. A very, very extremely good surgeon. So I called up Sir. Sir was kind enough to take my phone, and I was very young when compared to him. So he also said the best thing is to do a pneumonectomy. I was again not very convinced that I should lose a vascularized lung. What I did was re-anastomose the bronchus into the trachea. The problem was I was not too sure. It's an infected this thing. The lung was already kept collapsed for about 7 to 8 days, so I had to do a bit of decortication. And since the vascularity is not known, I had to put a flap from the intercostal vessels, based on the intercostal vessels in the flap. And I put 2 tubes, and it's again providence, I would say. The lung got expanded. The patient was discharged 12th or 13th day. More interestingly, on the 5th day, I get a call from none other than Dr. T.M. Joseph. He asked me, what happened to this patient? So I said, I did this. And he said, are you there? It was about 5 o'clock or 6 o'clock. And he came down to see this patient and chatted with me and had a cup of coffee. I just narrated this because, one, if you don't know, don't feel ashamed to ask a senior. They will tell you something. We may not accept it or not accept it. It's not a matter of concern, but always ask a senior for a wise advice. Number two, the seniors, many of them, even today, I believe that if you are good to them, they will come and follow up this patient and give a shoulder, a chat, a pat on your shoulder, which is a great boon at a young age to a younger surgeon. So never ever lose the chance to get a pat on your shoulder by your seniors. Now I'll tell you some sad stories. 5 minutes more, or some sad stories I'll tell. One is, there was a patient in, I think in 2005 or 2006. His name was Double. Why was he called Double? He's a 6'4" tall fellow, very stout, probably slightly bigger than Dibin in his stature. He was called Double not because of his height and weight. Everything he had in life was two. He had 2 wives, he had 2 houses, he had 2 cars, but he never stopped with 2 children in both the wives. He was a Muslim, needless to say, and he had 14 children in between the 2 wives. And this man came to me with a terminal esophageal carcinoma just above the GE junction. And the treatment of choice at those days and even today to many of the patients would be a definitive surgery, would be an Ivor Lewis. I was very pretty comfortable, very healthy fellow, no issues at all. Imaging was perfectly okay. His respiratory status was fine. His cardiac status was fine. So I operated. And unfortunately, this man leaked inside the thorax. You know the disaster of leaking esophageal anastomosis in the thorax. It was just about the time I was planning to go for a conference in Kerala chapter. That's the first conference I missed after becoming a member in 1985. Till date, I've missed only 2 conferences of the ASI Kerala chapter. And this man was responsible for me to be held back. I couldn't save this patient despite all his health, despite the fact that, a patient with a good performance status. And fortunately for me, the people took it. Only thing is that at this point of time, he was so healthy that so he remained alive for quite a long while to the agony of the family and myself. So, if it was a guy who was nutritionally debilitated, nutritionally weak, and cardiac status-wise, kind of okay or abnormal, they would have gone much faster. And we had to see this patient for more than 3 weeks, slowly dying in front of our eyes, not capable of doing anything. The last story of pain I'll describe. There is a patient who has had an emergency aortofemoral bypass done by my vascular colleague, and he was just discharged. He had in fact a blowout, and he had to be taken back to the theater. He had recovered from that, and he was discharged. About a week later, even before his sutures were removed, he came out with sepsis, and the sepsis was because of a calculus cholecystitis, and we had to control him and decided to hold on with the conservative treatment. He was in the hospital for about a week plus to control his sepsis, Whether the sepsis originated from the leg wound or not, we don't know. Anyway, the patient had a calculus cholecystitis. Sabit was there at this point when we did this case. No, anyway, you'll realize the story later. Yeah. This gentleman, we had waited. We pulled him out. He even had to go for a dialysis. He was a couple of dialysis because he went into acute renal failure. We pulled him out. And pre-operative, then we did ultrasound a couple of times. It was all unfavorable factors, but despite all those things, we had to decide that we'll go for a lap chole. And if lap chole was not possible, we'll go for an open chole cystectomy, because he had all unfavorable factors as far as the gallbladder is concerned. We attempted a lap chole, and he had a cirrhotic liver, and it was converted into an open chole because there was no way by which we could get it done. And he sailed smoothly. Only problem this gentleman had postoperatively was mounting ascites because of the cirrhotic liver. So I started him on 50 milligrams of aldactone, and it was escalated. Obviously, there was a drain and all those things. And his wife, when I went back after though we take a consent for all lap chole to open chole, we make it a point that we talk to the bystander with the dress inside the theater to say that, look, we are sorry, we are forced to convert because of these reasons to open to lap chole. I have gone there and I told that apart from this, patient also had a cirrhotic liver. So she said that don't disclose, doctor, the cirrhosis to him because his sister had a non-alcoholic cirrhotic liver and she died. So disclose it later. So this man was a very educated man. So I told him postoperatively that he had a cirrhosis liver, etc., etc. And the reason for starting aldactone, which I stepped up, and patient was discharged after a very, fairly prolonged postoperative stay. And by the time the patient was discharged, I think it was 100 milligram aldactone thrice a day, which is an acceptable dose as far as severe cirrhosis is concerned. Unfortunately, this patient came back about a few days later, and as usual, casualty reference, he was little disoriented, went to the medicine, went to endocrinology, they got admitted under medical care. I never knew about any of these things because no reference was coming to me. The medical people have written in that the patient has become hypovolemic because of aldactone. And the aldactone 300 milligram a daily dose was considered to be an unscientific dose according to one of the specialists, and they have narrated this to the patient's bystanders. Patient recovered well, but he had a big showdown that I was not, careful, and he went to the litigatory forum. The case is still on. The allegation is 300 milligram of aldactone is a suicidal dose for, given, and the surgeon has got no right to prescribe aldactone. It should have been done by the medical gastroenterologist. I'm just giving this example. I'll fight the case to the core, and I'm sure that I will win the core, because the reason I'm disclosing is that our own medical fraternity, without knowing what exactly is the issue, writing a unnecessary comment can lead on to many issues, though we are, not done anything wrong. So that is actually a painful thing. I think I should end with this. There is nothing in learning here. I just thought I'll share some good moments and bad moments that I have faced. Thank you very much. No questions, please.
Thank you, sir. Thank you so much. So before we conclude, I have to share, I have to remind you something. That is, next Sunday we are planning our Scuba 2026. So I called most of them. So please register and come in time. So registration starting by 8 o'clock and 8:30 the first presentation from Kottayam Medical College student, that is thyroid presentation. So PGs, please come in time, okay? So we have a glad news, that is one of our PG from Calicut Medical College. She received first prize in Torrent Young Scholar Award at Calicut, Calcutta in December 2025. So I invite Dr. Ilsana to receive the memento. So I request Dr. Santosh sir to present the memento to Ilsana.
And I take this opportunity to congratulate Ilsana and her mentors. And she will go to USA for a funded travel. You get $1,500 US. And she will get a free travel. And she will also be trained in USA for a period of 10 days, 7 to 10 days. And your hospitality will also be taken care of. So that is, so I request this information. I am giving this information because the younger generation of, next generation of her juniors and juniors should write this examination and come up through. It's a 4-layer, competitive examination, and you have done very well. Thank you.
So I invite Madhav Nambia sir to present memento to Santosh sir. I invite Ramlal sir to present memento to our PG, Dr. Sonu. I invite Bashir sir to present memento to our guest speaker, Dr. Mohammad Niaz. Thank you, sir. So, I feel highly privileged to stand before you on behalf of Calicut Surgical Club to deliver the vote of thanks. This being my first meeting, I am deeply grateful for the immense support I received from the executive members, my teachers, especially Srijan sir and Gobi sir, and our beloved President Dr. Arunas. First and foremost, I extend my sincere thanks to all the senior faculty members who gathered here today. A very special word of gratitude to my dear Santosh sir. I'm not sure how it happened that on my very first program, he could be with us. And his presence and the way he showered his blessings through such an inspiring talk made this occasion truly memorable. Thank you, sir. I would also like to express my heartfelt thanks to our guest speaker, Dr. Mohammad Niaz, who shares a brotherly bond with me. His excellent presentation actually was a truly eye-opener for everyone here, including myself. His talk on concept of antibiotics, prophylaxis, and how long the antibiotics should be given, what are the different antibiotics. This is excellent presentation. Thank you, Niaz. And my sincere appreciation goes to the our postgraduate presenter, Dr. Sonu, for the confident and well-delivered presentation. I also extend our sincere thanks to our sponsors, Sonoris Pharma, for their generous support in making this program a success. Finally, I thank all my friends, colleagues, and postgraduate students for your active participation and support. Once again, thank you all. So the meeting is adjourned for dinner. A national anthem, sorry. जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल वंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गादा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।